Hello, everyone. This is Matt Takahashi, and we will be starting the program in a couple of minutes, so please hang on. Thank you. Hello, everyone. Gabe, are you there?
I'm here.
Okay, great. Well, this is Matt Takahashi, and I'm the host for our leadership series, which is a complimentary professional development program sponsored by Executive BioSearch for leaders in the molecular diagnostics and tools domain. Today, I'll be joined by Dr. Gabe Bien-Willner, who's the medical director of the MolDX program at Palmetto GBA, a Medicare administrative contractor, MAC. MolDX seeks to understand the molecular testing landscape to implement payer controls, coverage, and to set policy for affiliated MACs, which currently covers 28 states. He's a leader in the precision medicine space and practices as a board-certified anatomic pathologist and molecular genetic pathologist. Throughout his career, he's been active in research, development, and advancement of molecular diagnostic services, specifically next-generation sequencing. He has worked closely with clinicians to develop clear clinical diagnostic and treatment pathways directing precision medicine programs for community cancer centers. Today, he'll be discussing how to navigate policies of Medicare, how coverage is determined, and the metrics Medicare uses to measure these tests. He'll conclude with a practical example where the audience can weigh in whether a test meets Medicare criteria, and he welcomes any questions during the presentation via the chat room, and he'll do the best he can to respond, or feel free to email him at the address provided at the conclusion of the presentation. Thank you for joining us today, Gabe, and we look forward to your presentation.
Thanks, Matt. Just making sure everyone can see. I switched to the first slide on the deck. I thank you all for inviting me into your den or home office or living room or wherever you all are. I hope everyone's safe. What I'll be talking about today, Matt discussed in a little bit of detail, but we'll be talking about MolDX and backing up a little bit from that, Medicare and how coverage is determined. So just as we start here, I'll introduce myself a little bit more. So I'm a chief medical officer with Palmetto GBA, which is a Medicare administrative contractor that houses the MolDX program, of which I'm the medical director. And you may have heard about us. Anybody that's in the molecular diagnostic space and seeks coverage, eventually, most of them eventually will end up dealing with us. And I often get asked questions about how coverage is determined, and so that's the basis of this talk. And so just at a high level, what is the MolDX program? This program was created as a pilot program by the Centers for Medicare and Medicaid Services, or CMS, to utilize specific expertise in the molecular diagnostic space and for a variety of tasks. One is to identify relevant tests and to create administrative processes for handling these difficult tests. We'll get to why that is in a minute. Determine coverage policies for these tests, and occasionally, when necessary, also determine reimbursement. By the way, if anyone works within the coverage and reimbursement landscape, you will likely know that there are a lot of acronyms involved, and those of us who are in this space just shoot them out of our mouths without thinking twice about it, not really knowing that most people have no idea what we're talking about. In fact, when I first joined the MolDX program, I remember standing around with the other medical directors, and I remember being in a conversation where at least 4 or 5 sentences went by where I didn't understand a single word of what was said. So in order to try to help you guys with that, at the top left of the screen, I'm keeping a little box of acronyms that hopefully if you hear me say something, you have no idea what I'm talking about, look into that little box. It might explain it. So I talked about MolDX program being a program within Palmetto GBA. But I think one important thing is before we really can get into how the MolDX program works, I think it's really important for people to understand how Medicare works, because clinicians, providers in general have not a very good understanding of this. So Palmetto GBA, who pays my salary, is an entity, a MAC, a Medicare Administrative Contractor. And what these companies do is administer the Medicare program. Medicare is not a singular entity that is housed in Washington, D.C. There's a set of laws and rules and principles, and then contractors actually administer this program. And we'll talk a little bit about that now. So what the MACs do, well, one of the major things that they do that most people, how they interact with MACs is that they process claims for providers on behalf of CMS. So when you perform a service for a Medicare beneficiary, you don't send your bill to Washington, D.C. when you want to get paid by Medicare. You submit that claim to your local Medicare administrative contractor for payment, and they have the authority to act on behalf of CMS to process those claims. They create policies for coverage within their jurisdictions, and those policies are based on guidance from applicable law. We'll talk a little bit about that too. And they'll also determine pricing if there is no CMS existing pricing. They also cooperate with, but are not actually involved with enforcement agencies. We'll talk about that as well. So how the Medicare program is structured is the country is broken up into little divisions, which we call jurisdictions. And these jurisdictions are up for bid to administer the Medicare services for Medicare. And so there's several Medicare administrative contractors. The ones here are the current ones that have these current jurisdictions to provide Medicare services. The jurisdictions are broken up by a series of letters, and you can see them on this image as well. So in order to be able to administer or adjudicate claims on behalf of Medicare or CMS, these MACs get to write their own policies to interpret law, and they do that by writing coverage determinations. So it's important to describe that there's different kinds of policies. There's the national policies, which are actually created by a central office of CMS called CAG, or the Coverage and Analysis Group. And those are overriding national policies. And then within these different jurisdictions, the different MACs write local coverage policies. And these are written by contracting medical directors, or CMDs, that are hired by these entities to act as the clinical experts in creating these policies. So it's important to note that these aren't equivalent, that first and foremost, the law is the most important thing, and national coverage policies must follow those laws. And then the national policies supersede any local coverage policies. In fact, one of the steps that we'll talk about in the process of making local policies is that they cannot supersede national policies. And all local policies are reviewed by CMS in order to ensure that they do not infringe upon national coverage policies. So how do CMDs write policies? So again, we have to apply laws and policies that are applicable to the Medicare program. And there's a hierarchical structure of these things. First and foremost is the Social Security Act, particularly Title 18 of the Social Security Act, which defines the program. And then the rules and codes for the execution of the program is set out in the Code of Federal Regulations, or the CFR. And furthermore, the central office also provides guidance to the MACs on how to run the program through manuals, for example, the Program Integrity Manual, or PIM, as well as other things like change requests or technical direction letters. So that's a high-level view of how Medicare services work, particularly around policies and CMDs. Obviously, many of you are interested in laboratory testing and how this may apply to you. First and foremost, if you're a lab and want to be considered for coverage of your test, the most important thing you should think about is whether your service that you're performing is reasonable and necessary. This is a critical component of the decision-making process for coverage. This is defined in the Social Security Act, Title 18. Another consideration is whether the service that you're performing is a covered benefit as described in the CFR. For example, the CFR explains what is within scope and what is not within scope of this program. Often I get asked questions about why we, particularly in genetic testing, why we don't cover screening tests when they are very important for the population, and often very angrily ask that question: how can we not understand that some tests are both reasonable and necessary as screening tests? And the answer is not that they're not reasonable and necessary, but that strictly screening test is outside the scope of the Medicare program, and as such is not a covered benefit. You should also consider how claims can and should be processed. And of course, the Medicare program has a defined population, and if you want coverage within the Medicare program, you should think about whether your test is relevant in this population and has been demonstrated to be relevant in this population. So let's explore the idea a little bit further of what reasonable and necessary is, because my belief is that if people understand these concepts well and how they apply to laboratory testing, there'd be a lot more clarity in this space. So specifically, there's a quote here from the Title 18 of the Social Security Act, which defines this. The Social Security Act allows coverage and payment for only those services that are considered to be reasonable and necessary for the diagnosis or treatment of illness or injury, or to improve the functioning of a malformed body member. The way that that's interpreted to mean, and what subsequently you should interpret this to mean, is that does this lab test or service that you're performing result in information or provide information that can result in management decisions that improve patient outcomes? So this also highlights something that's interesting. So we try to be very objective in this process, but ultimately there's different ways of interpreting words, and that comes up again and again. And because of this, we have CMDs who are physicians and thus theoretically experts in this space and can utilize their judgment to render decisions on coverage. For example, the term improved outcomes, what does that mean? You could interpret an improved outcome to mean that the overall survival of patients can be better if they're treated one way versus another. But it could also be interpreted to mean something entirely different. For example, that a test may inform a clinician that a specific service may not have any impact on the patient's outcomes, and therefore they could be saved from having to be exposed to a service or drug that may have negative health consequences or put them at risk for negative health consequences. So for example, chemotherapy may be good for cancer or some cancers, depending on the type of chemotherapy, but there are negative consequences to taking chemotherapies. And if a lab test informs the clinician that the patient will not benefit from that chemotherapy, the patient not receiving that chemotherapy improves their outcomes by not exposing them to a toxic substance. So regarding pricing, MACs can determine pricing if CMS does not have an established price for a test in the clinical lab fee schedule. CMS defines two types of processes for coming up with a price for a test. These are the crosswalk and gap fill. Crosswalk effectively means that there is effectively similar service to the service that we're considering, and therefore it should get the same price. Gap fill is when there is no such service that is equivalent, and there are and the way CMS utilizes gap fill and the way the MACs are employed to use gap fill are a little bit different. For the central office, gap fill is what other payers are paying for services, but for the MACs, CMS defines essentially 4 methods of determining gap fill. It's a little bit outside the scope of this talk, but this is what, when we create pricing, these are the things that we have to consider. All right, so we talked a lot about things that have nothing to do with molecular diagnostics, but I think with that general frame of understanding of what MACs do, how Medicare is run, you'll have a better appreciation now when I get into the specifics of the MolDX program. So first, why is there a MolDX program? What does it do? So it's important to know that molecular tests are different than general clinical services and established laboratory service in that they require a very specific knowledge set that many CMDs and clinicians lack. That is an expertise in a very technical field and in genetics, which is not common to all physicians. Additionally, this field is hampered by a lack of well-defined billing codes that makes claims processing quite difficult without additional processes. So, for example, a lot of tests are not easy to understand for the payer. So a payer's job is to understand why a service was rendered and if it was necessary, reasonable and necessary to render that service. And the way we traditionally explain as clinicians to payers what we did is we give them an ICD-10 code for that patient, so what's wrong with that patient, and a CPT code for the service that was rendered. Well, what test was that? Well, for this issue, many CPT codes don't actually define what service was rendered. They may be defining a methodology, they may be defining a gene, but not why that gene was performed or for what specific indication. There's also, to compound this, there's a lack of standardization in testing that makes it really hard to know if any given test is both reasonable and necessary. So so I can give you lots of examples here, but a common one that I'm particularly interested in is NGS testing. And there's a specific CPT code for NGS testing in cancer that defines a panel of 5 to 50 genes. That's 81445 is the CPT code. And all it tells you is that you sequence between 5 and 50 genes. It doesn't tell you which genes or why. So if you could have two completely different tests, one that's geared only for lung cancer and one that's only geared for colorectal cancer, and you would build them with the same CPT code. And when the payer gets that, they don't know which one of those two tests you rendered on that patient. And so there's just not enough specificity in the coding for them to understand what was done and why. So let's go back to the first slide, which is what is MolDX and what does it do? And how does it try to address some of these concerns? So again, MolDX was created as a project within CMS, although now it's been in operation all of 8 years. and it's administered by Palmetto GBA as part of a joint operations agreement between 4 MACs. That includes Palmetto, Noridian, Wisconsin Physician Services, or WPS, and CGS. We leverage expertise in the molecular diagnostic space to create processes and policies for all of these MACs. Now, these policies are still subject to independent review and acceptance by the partner MACs. And in a way, we don't do anything different than any other MAC service. So we review the evidence, we write policies, we help adjudicate claims. We don't do anything different, except we only focus on this one niche area that is difficult for most MACs to be able to handle. So if you look back at the image of the United States, this is the same map I showed you before, but now I've replaced some of the individual MAC names with the ones that are covered by the MolDX program. And you can see that actually we cover 28 states, which is more than half the country, with our policies and processes for adjudicating claims. So that means several things. One is that not only do we only cover these areas, but many other payers will read our policies and copy our policies. So when we make a determination, it usually resonates pretty broadly in the entire country for many payers. We also have some very specific requirements for being able to process claims in the MolDX program. And this is in part to make up for some of these gaps in how tests are performed. I mentioned that many different tests can be created under the same CPT code. This isn't implied to be a negative thing. The point is that a lot of laboratory developed tests exist in molecular diagnostics, which is not really so true in clinical chemistry or infectious disease testing. And that's not wrong. In fact, that's probably a very good thing. But payers have a really hard time understanding what the difference is between any two lab developed tests, in addition to these CPT issues. And so we've created specific requirements to be able to process claims for molecular diagnostic tests that help bridge or fix some of these problems. So one way we do that is by the creation of a unique identifier that can be created for any specific or unique test. We call them Z identifiers. You may have heard of them as Z codes. And that allows us to know when you submit a claim, that you submit a claim for this specific test, and we know the utilization and we know the indicated use of that specific test, because you'll be providing us that information. We also require a technical assessment to be performed on that test to ensure that the test performed complies with the fundamentals of assuring that the test is reasonable and necessary. All right, so you want coverage for your test. What should you do? This is going to be a fairly directive explanation of the process that you will go through and the things that you should be considering before you begin and as you go through the process. First, you should review our existing coverage policies to see if any of them apply to the test that you're performing. It's important to understand whether if it fits under existing policy or if a new policy may be required, because the processes will be different and the timelines for potentially getting coverage are also very different. We'll go through these processes in a little bit. So 3, when you're ready to proceed, your test is done and validated, you want to register your test with DEX. DEX is a program called Diagnostic Exchange. It's owned and operated by another entity called Change Healthcare. It's at no cost to the user. You register your test, and that's what enables you to get a Z identifier. We at MolDX don't actually provide these codes. The DEX software provides the codes. When you get on this site, you basically explain what your test is at a fairly high level and state the indicated uses of your test, the expected CPT codes that you think are appropriate for your test. And DEX will turn around and give you back a Z code. Once you've got that information, you will then submit a formal application to the MolDX program. The instructions for doing so are actually on our website. But you'll be submitting to us information that we need depending on what service you're performing. And we'll also pull some of the information from DEX as well to be able to go through our process of reviewing an application. So what is the workflow of this process? We're going to first start off by assuming that the test that you perform fits under an existing policy. For example, you perform a next generation sequencing test for hematopoietic malignancies or suspected hematopoietic malignancies for which we have an existing coverage policy. In this case, you would submit your DEX application, you would get a Z code, you would submit a formal application to us. We would then review your application and do what we call mapping, or ensuring that your test is mapped to the correct CPT code and other identifier or necessary information needed to adjudicate a claim. And we'll go through the TA process if it's necessary. In this case, or in-depth technical assessment of your test. In this case, if you're doing an NGS test, absolutely you would get an in-depth technical assessment of your service. Assuming that we approve of your service or your test and it passes the technical assessment, we will then add this to what we call a shared edit file, the master edit file, that is then sent to all the partner MACs. And that edit file informs their claims adjudication systems how to process this claim. In fact, it would be telling them to pay the claim in the conditions set forth for the indicated uses of your test. And then we tell you to wait about 2 weeks for all the systems to be updated, and then you can process claims. It's also important to know that there's a big distinction between how Medicare operates and how private payers operate. Private payers often require you to go through a pre-approval process, and they have 90 days to pay your claims after reviewing of whether the service that you performed was necessary. Medicare doesn't work that way. Medicare pays claims within 15 days if the appropriate information is provided. So we have to have a very rigid and strong sort of edit system to try to ensure that only the proper claims are paid. The process from beginning to end, depending on what service that you're asking for us to cover, can take anywhere between 2 weeks and approximately 2 months. Although these days we're running a little bit behind because of COVID-19 and a series of other CMS central priorities and some resource constraints. But in general, we try to turn these around in about 2 months once we get a receipt of completed documents. Sometimes we don't get complete documents. Sometimes we get partially complete documents. It doesn't count. Once everything is ready for us to review and everything is there, we could turn these around fairly quickly. Now, if you don't fit under an existing policy and require a policy for coverage, again, policies determine what is reasonable and necessary. They inform the public how the MAC views services as fulfilling the criteria for being reasonable and necessary. So we still have to go through the same exact processes as you saw. In fact, the blue boxes are the same as before, but now you'll notice that there's a lot more red boxes. CMS has created very regimented process for creating policy. And a lot of the changes in this process are good in that they're intended to create transparency to the process and involve the provider community to have a stake and say in this process. So some of the changes that can occur if a policy is required is we start not just with an application, but also in an informal meeting. This is not a necessary component, but most providers choose to go through an informal meeting. which allows the provider to meet with the MolDX staff and explain their test and ask for feedback in terms of meeting the criteria necessary or understanding the evidentiary review process that MolDX will undergo. They could then take that information and continue to develop their test or decide that they are ready to formally submit for a coverage policy. One change that's been made in the past year and a half to the process is it used to be that the payers would just decide whether a coverage policy was necessary or not. Now, providers actually have the ability to come to the MAC and ask for a policy. When they do so, under our new rules, payers have to respond whether the request is a valid request or an invalid request. Getting a valid request doesn't set a timeline, but it informs you that there's a request and it goes on a queue for the MAC to actually create an LCD or local coverage determination. Once we decide to move forward in writing a policy, we can choose to initiate a feedback session with a contractor advisory committee or CAC. You may have heard of these meetings. They're a group of providers or potentially expert providers or opinion gathering session where we can ask specific questions to these physicians regarding the kind of information we would need to be able to come up with a sensible coverage determination. In a way, we can't give people copies of a policy before it becomes publicly available, but we can ask questions to experts in the community to gain a sense of whether the policy is on the right track or not. Now, this isn't a necessary component, but it's always good to get expert opinion on the subject matter for which you're writing a policy. You know, we have expertise in molecular diagnostics, so we don't need a lot of outside expert opinion necessarily on a methodology, but we may need expert opinion on the use case. If a test is to be utilized in kidney disease, it might be good to get nephrologist opinion in that process. We then take that information if we need it for the policy and we draft the policy. Once a policy is done, you think that that's what takes the most amount of time. But in fact, generally in the entire scope of this, that might take the least amount of time. We have to then go through a very, again, as I stated before, regimented series of steps that have defined time periods. When the draft policy, for example, a draft LCD is created, it's not made publicly available right away. First, it goes to CMS for a 21 business day review in which CMS can determine that that policy is allowable or not allowable based on national coverage policies. When that 21-day window expires, we are then able to upload that policy, that LCD, to the MCD or the Medicare coverage database, which is a publicly available, viewable repository of all CMS policies. When that occurs, that starts the comment period. This is something that's changed recently. It used to happen at a different time, and I probably won't go into it unless there's any questions on it. But just be cognizant that once the policies are now out there in the public for viewing, that is now being determined the start of the comment period. What is the comment period? That is the point of time in which anyone who's a provider within the jurisdiction or Medicare beneficiary can review these policies and comment on the policies. Basically, you send an email to us and explain and tell us what you think about the policy. You could tell us it's the best policy you've ever seen, which is what I expect all of you to say all the time. Actually, I'm just kidding. We see this as a constructive, necessary process of the generation of a final policy. So we really want to get honest feedback. Typically, we get a lot of feedback from professional societies in our space here usually AMP and CAP, but other relevant associations, depending on what the test is for, will also weigh in, as well as the providers themselves who perform the services, or other providers who don't perform the services but feel that they have a word to say about the policy. There's a definitive open and close window for providing those comments. They must be at least 45 days long. We also must have an open meeting. This used to be a meeting that initiated the beginning of the comment period, but now that is no longer the case. This is a public forum where the providers who perform these services can get in front of an audience and explain their service and how they perform the service and why there should be coverage or non-coverage for the service that's rendered. The comment period, as I said, is a minimum 45-day period for responses to come in, after which point there is no more comments that can come in to be part of this policy. The CMDs will then take all of these comments, review all of these comments, and use the comments to help inform the policy. If, based on the comments, changes to the policy have to be made, we can make those changes and still be within scope of this process. Once all these comments are reviewed, we will finalize the policy. Finalizing the policy initiates the beginning of another fixed phase, which is called the notice period. The notice period is a 45-day, these are business days, where the community will be made aware that this policy is not yet effective, but will be effective on a specific date. That time is then used by the MACs, by the editing systems, to be able to update all their internal software and processes to be able to handle these new policies. At the same time as we finalize a policy, we'll also finalize a series of articles. One is an article responding to every comment that we received. And then another article will be a billing and coding article. So it used to be that the coding and billing and coding were part of the coverage determination of the LCD. Now they're actually been extracted and are a standalone document. Once that 45-day notice period is up and that policy goes into effect, at that point, the information from that policy will then go into this edit file system that's then shared between all the MolDX partners, and the providers will be able to process claims. So that was a lot more stuff, and because of that, the timeframes go from 2 weeks to 2 months to about a year to get these things done. So policy outcomes. I'm not sure I said this before, but there's 2 kinds of policies. They could be a coverage policy saying, based on the evidence, we are going to cover X and X services because of the following rationale. Or it could be the opposite. We reviewed the evidence and we feel that these services should not be covered. Now, in general, outside of MolDX, most policies are non-coverage policies because most services, once they get building codes associated with them, are determined to be reasonable and necessary in and of themselves. And so the only way we can not pay for things in general is to explain to the provider community that we will not pay for the following services, and here's our rationale. MolDX is a little bit different because of some of the things that we mentioned before, wherein typically we don't cover molecular services unless we have policies that explain why we do cover them. Now, that's why it's important to write broad policies so lots of tests can fit within those services that fulfill the criteria for coverage. And so this is part of a reflection on the fact that this is really a rapidly evolving field that is not really well understood by many people. So what are the outcomes? As I mentioned, an LCD that is a coverage policy or an LCD that is a non-coverage policy. Well, what if you're a provider and you don't like the result? Well, there's a formal process to change that result. And the first one is a reconsideration of the policy. So anytime there is any evidence that we didn't consider in formulating our policy, or if new information comes about, and information should really here mean published evidence in a peer-reviewed journal, then the stakeholders may have a legitimate claim for a reconsideration of a policy. In fact, it should also be understood that this is not a negative thing. These policies are living documents, and it's expected that the evidence will change over time. Services that are considered reasonable and necessary today may not be reasonable and necessary tomorrow if better services come about or evidence comes out suggesting that that these services don't perform or don't have necessary value. We'll get to that in a minute. But it's also possible that we made a mistake. We didn't consider all of the evidence. And in that case, you could submit a request, just like for a new policy, but you could submit a request for reconsideration. And just like for policy, the reconsideration request will be responded to with a statement from the MAC, whether the reconsideration request is valid or invalid. But it's important to understand that the submissions must be provided with new published evidence. If you say you don't like the policy and you do not provide an evidentiary basis for that, then that is not a valid reconsideration request. If after we reconsider your request and determine that, sorry, but we think our policy is still correct and we're not going to change anything. By the way, a valid reconsideration request, even if we decide not to make changes, should take a policy back out for comment period. But regardless, it goes through comment period and we still don't make any changes to that policy. There is additional recourse, for example, filing a claim with an administrative law judge. However, this now will take potentially years to resolve. All right, so this is probably the bread and butter, or the I guess the meat of how we think. To understand whether a lab test is both reasonable and necessary, we consider that a lab test must perform and demonstrate value in three different essential components of a service. One is that the test demonstrates analytical validity. Another one is that it demonstrates clinical validity. And the third is that it demonstrates clinical utility. And I'm going to break these down because these are really important concepts. And I hope you guys didn't already phase out and aren't already asleep, because if you take anything away from this talk, it should really be this. So what are these? And I think in general, people conflate these terms. And I think it's important to really have a clear understanding of the distinction between what these are. So AV should be thought of as this. How well does the test that you're performing detect the thing that it's seeking to detect? In general, it's a mutation, it's an analyte. And the way we demonstrate analytical validity is through analytical and clinical validations. What is the sensitivity of the test? What is the specificity of the test? What is the limit of detection of the test? These are all relevant things that we look at as a component of analytical validity. Notice that analytical validity has both an analytical and a clinical validation component. Then there is clinical validity, which is not the same thing as a clinical validation. Clinical validity relates to how well that thing that you say you measure actually relates to the presence or risk of the disease entity that you're evaluating. So to explain this a little bit more, actually, let me go through the last one and then I'll kind of use an example. And then there's clinical utility. Clinical utility is the so what factor. Clinical utility tells us how clinically impactful the test is. In order to be clinically impactful, the information derived from the test has to be leveraged by the treating physician to do something different that can potentially improve the patient outcomes. If it doesn't inform them in some actionable way, then a test doesn't have utility. So let's pick an analyte. I sometimes just make one up here, but in this case, just for the sake of brevity, let's take a PSA test. PSA test is a serum marker. It's a protein marker that's floating around in the blood. And let's say you create a test to determine PSA levels in the blood. Well, the analytical validity would be demonstrating through an analytical and clinical validation using real-life clinical samples that in a real-world environment, you can accurately detect the PSA level of a patient. The clinical validity would be demonstrating that the PSA marker that's floating in the blood has direct relevance to the risk or likely diagnosis of prostate cancer. That link, that established scientific link is clinical validity. And then clinical utility tells us, what are we going to do with the information once we get it? If we can't do anything with the information, then there's not value and there's not utility. In this case, knowing that the PSA levels are higher informs the clinician that they may need to biopsy that prostate to look for prostate cancer. So that because it's assumed that that's a real established thing, which might be questionable in PSA, but for the sake of this explanation, that would definitely have clinical utility. Your test has to demonstrate analytical validity, and clinical validity and clinical utility have to be understood for the analyte that you're measuring and the clinical services relevant to the use of this test. So you must have all three of these things to have coverage. Only some of them may be directly relevant to the test you're performing. So for example, in PSA, it's already understood that there's clinical validity and that there's clinical utility. So if you want to create a new test for PSA, you may, assuming you're still measuring the same analyte, you may only need to define analytical validity because the other things are already known. This is what we consider the chain of evidence from beginning to end. You have to be able to demonstrate all of these things for your test to be reasonable and necessary, but not if something's already been determined, you don't have to reinvent the wheel. However, you must show a direct link between what you're doing or have done and what other people have done. So if you're measuring serum marker X, and it's kind of like serum marker Y, and we know that serum marker Y has demonstrated clinical validity and clinical utility, you must establish the validity of X either directly through the disease or defining an established relationship between marker X and marker Y. It can't be assumed that it exists, right? So I think this is sometimes a misconception that the test itself must demonstrate clinical utility as well. Oftentimes, the test can't demonstrate utility. It's that the test advises on the use of a therapeutic intervention, but that therapeutic intervention must also have clinical utility. And if it does, and the choice of using that intervention or not is dependent upon the assay, then it's implied, it's already understood that test will have clinical utility. I know there probably will be lots of questions about this, so let me just move on and then see what we have time for. All right, so what I'll do now is just go through a few updates of recent policies that may be of particular interest, things that have changed over time, things that are new, and I'm going to try to keep this brief because I know this will also potentially raise a whole bunch of questions. Okay, so NGS, NCD Part 2. As you may know, there's a National Coverage Determination 90.2 for next generation sequencing in cancer. This went through a reconsideration, and several months ago, CMS put out a national final policy that changed some of the language in the NCD. Of particular importance, there was a special section added for germline testing, but there was also a section and some wording that was changed. It used to say that if for coverage, for national coverage, and for MAC consideration of subsequent coverage, the patient has to have recurrent, relapsed, refractory, metastatic, or advanced cancer. That's still true. and has not been tested by the same test. It used to say for the same diagnosis, but now that's been changed for the phrase the same genetic content. There's been a lot of questions as to what that means, and so I wanted to help clarify that. What this is intended to mean is if there is a clinical suspicion that the genetic content of a tumor has changed, then the same test could be performed again. A great example of this would be non-small cell lung cancer. Patient has a EGFR mutation. They're put on erlotinib for 4 months, and then and they're responding really great, and then they have recurrence. Well, the underlying implication here is that the genetic content of that tumor is now different, and so it may be relevant to test that patient again because they may have a subsequent T790M mutation in EGFR that could then advise the clinician to use a different drug. We also have a series of new foundational policies that are effective. You've heard me talk about one of these already. They've been in the works. They were in the works for almost a year. They were actually sent to the public in May of last year, but were not finalized until February for a variety of reasons. One is NGS testing and lab-developed tests for solid tumors, basically taking some of the language from the national policy, but applying them to lab-developed tests. And then there's NGS testing for myeloid and suspected myeloid malignancies, which is similar for myeloid malignancies, but also falls outside the scope of the NCD in that it can also be used in patients who do not yet have the diagnosis of a myeloid malignancy or a myeloproliferative disorder. We also have articles, I think, that are very relevant that define targeted and comprehensive profiles. Don't quite have the time to go into that right now. I've already explained this. We also have another foundational policy that is currently in notice period, which will be effective at the end of this month, which is a repeat germline testing policy. You can all go and read that and check it out. Basically, what it's saying is that germline testing is services for a specific test is limited to once per lifetime for the same test covering the same genetic content for the same information. Now, we are very explicit about this language here. The intent isn't to say you can only bill for one CPT code once ever. It's to imply that you should only bill for one CPT code once ever unless there's some real reason why you need to do it again, in which case you're going to have to tell us what that is. But it's within scope of the policy that, you know, it's understood that tests change over time, that they get better. And there could be information that wasn't identified the first time, but maybe identified on subsequent time because of improved testing technology or looking for different types of variants. But also we explicitly call out panels. So if you test one gene and then you want to run a panel because you didn't get the information you wanted, and that gene was also on the panel, it doesn't render that rest of that panel not covered. Explicitly, the policy states that as long as the rest of the information is reasonable and necessary, we don't care if there's some repetitive or redundant information there. And then last but not least, there's been a lot of discussion around pharmacogenomics testing. We put out a draft policy in October, or a couple of policies in October. Some of the language here is reflecting what was in that initial draft policy. Basically, that we hope to be covering pharmacogenomics tests for validated markers, whether they're single gene or within panels, that are really only covered when there's a drug with a known gene-drug interaction that's being considered for use. These tests can't be used for screening purposes for obvious reasons. I will just say stay tuned on that one. We put out new policies on the MCD. Those come out on Thursdays, so just be looking for that. Okay, we only have 7 minutes left. I had an example of how we do this in action, and I was going to propose to kind of explain a theoretical situation where I would describe a new test, typically how we are provided these tests, go through some of the evidence with you, and then ask you guys to determine whether it should be covered or not covered. But I don't think we have the time, and so we're just gonna bypass this, and I'm just gonna try to refer to some of the questions. I guess Matt, if you want to get on and talk about which questions we're gonna address, because I've probably seen 100 things come up. I don't know where. Should I just pick and choose?
You can pick and choose. It seems like there's a lot of interest surrounding AV, CV, and CU. And one of the questions was, is there any updated direction regarding the establishment of CU, and kind of expanding on the difference between clinical validation and clinical validity? That is a start. And I think there was other questions surrounding that topic.
Sure. So I think I covered that. Maybe I didn't cover it well, or maybe that question came up before I explicitly talked about it. So clinical validation and clinical validity are very different concepts. Clinical validation is part of analytical validity of a test. It's just unfortunate words that sound very similar but have very different meanings. Clinical validity is specifically a tie between the understood biology of disease and that thing that you're measuring. Oh, you're okay. Yeah, let's go back. Good idea. We leverage different models for some of this. ACCE model is a good high level explanation of some of these concepts. But again, validity and clinical validity and clinical validation are very different concepts. Clinical validation is part of a standard laboratory process of ensuring analytical validity. Clinical validity is nothing to do with the performance of your test. It's everything to do with what does the result mean? Is it have some real direct tie to a disease? You could have a perfect test with 100% sensitivity and specificity, and that test doesn't have any clinical validity. It has to be established. Okay. Thank you for whoever pointed that out. All right. We can start at the very beginning. The first question is, can anyone hear audio? If you can't hear audio, I'm sorry, you've just sat in front of a blank screen for an hour.
So if we started at the beginning, there was questions regarding gap fill.
Yes.
What are the 4 methods for gap fill, and just getting some clarity on that and detail on how pricing is set using that method.
Absolutely. So when MACs do gap fill, they're told they can use series of information sets to determine. Some of them are a little vague and some of them are very specific. So one of the ways is to look at what is the established price, or how much does the provider want to get paid for the service, and how much are they discounting the price. So CMS doesn't want to get paid less than anyone else, or doesn't want to pay more than what other payers pay. So they're going to ask, what do other payers pay? And then when as a provider, what do you charge? What do you charge with discounts? That's one. The other one is, what do other payers pay? And then another one is, how does this relate to other established tests? Is it similar to other tests? So it's kind of like crosswalk. And then one that we try to leverage a lot of is, what is the cost basis of performing the service? I think I personally feel that that we never want to pay less for a service than what it costs to perform a service. If we determine that a service is reasonable and necessary, labs should be able to perform those services and not feel like they're losing money on every test they run, right? So understanding what their cost basis is a good way for us to ensure that we don't cross that line, and that we want to enable labs to have reasonable margins for overhead and profitability too. So that's one way we often use to leverage. In fact, we have to price tests every year. For example, PLA tests all have to get priced. And we have instituted a new policy, which is that anyone who needs pricing is going to fill out a form that's going to tell us what their cost basis is as much as possible. Mm-hmm. So we'll use a combination of these things. We want to be pragmatic. Sometimes one approach works really well, and sometimes another approach works really well. So again, it's at our discretion to do that. However, we also are trying to make this a very reproducible and fair and equitable is a better word than fair, process for doing this.
So when there's when a different MAC has a different policy on the same test, is that an indicator, or how do you address that?
Well, so the different policy or different price?
Policy.
Are we talking about pricing? We're talking about policies. Right. So the thing about molecular diagnostic testing is most lab developed tests are in a single site on a single jurisdiction. But in general, some of these classes of tests like NGS and cancer are going to be done in all the jurisdictions. And the reason why CMS was created the way it was with jurisdictions and contractors was that they expected there to be regional differences between different parts of the country about what should be covered or when or why. Now, it's also problematic when doing a service that's considered essential in Tennessee is not considered essential in whatever, Florida, right? So there's a pro and a con to the approach of how CMS was laid out. However, that's the way it was done. So if there's two different MACs with two different policies and they contradict each other, that's just the way it is. There's different, the MACs have discretion to write their own policies for within their own jurisdictions. Now, that's why there's also programs like MolDX where multiple jurisdictions generally have all the same policies. And so we don't have that kind of variation. Although more and more MACs in general are starting to work a little bit better together and try to do things more or less in unison. But if things were totally in unison, then let's be frank, it probably would be no need to have jurisdictions. We could just have one national jurisdiction where everybody's the same. So I guess the answer to the question is, if there's different policies in different jurisdictions, there's different policies in different jurisdictions. And for that reason, sometimes labs just pick up their stuff and move from one jurisdiction to another where they think they're more likely to get favorable coverage.
Got it. Okay. One of the next questions are LCDs jointly developed among the MolDX participating MACs, and how does that work?
Yeah, so that's a good question. So in general, the answer is yes. Now, the real expertise is in the MolDX program as it, within Palmetto, but we partner with these other MACs and they all have a say in the process. So the other CMDs at the other MACs that weigh in aren't necessarily experts in the field, but they are physicians and their opinions do matter. So our general process is that we write the policies and then we share them internally to the other JOA CMDs, and we ask them for feedback. And they'll give us edits. They'll give us whether they like it, they don't like it. And in general, we don't move forward unless everyone agrees to move forward. Once everyone agrees to move forward, then we create a final draft, and then that draft goes to CMS. So everyone has a stake.
Okay. Would you like to pick any of these questions, Gabe, or how are you?
Sure. All right, let me see. Let me go back from the back to the okay, here's a question about NGS oncology tests. Does CV and CU apply to panel or to each gene? So I think the interesting part of this question isn't about CV and CU as much as how do we consider panels of things versus single analyte services. So in general, there's been a slight philosophical change in how we approach molecular testing since my tenure as the director of this program. It used to be at one point, the previous medical director would say, we're living in a different world where everything was more or less analyte specific, meaning if you did a panel of 5 genes, that meant you did Sanger sequencing of 5 genes. And each gene you did added that much more cost. So if you were going to do a panel, let's say for, I don't know, colorectal cancer, and you have all the MMR genes as part of a panel, it was the prior regime would say, if you're going to do a panel, each and every one of the analytes in that panel must be specifically reasonable and necessary to the explicit patient. Otherwise, the entirety of the panel is non-covered. What hasn't changed is that the idea is the unit of service, the thing that you are billing for, you're either doing a single gene test or you're doing a panel. If you're doing a panel, then that panel has to be reasonable and necessary. If you're doing single gene test, then that single gene has to be reasonable and necessary. You've got some new articles sort of defining single gene versus panel and how those interplay with each other. If you're doing multiple genes at once, it's a panel. If you're doing one gene at a time, then it's single gene testing. But the entire thing is reasonable and necessary. You either need to do a panel because a single gene is not sufficient, or you do a single gene because a single gene is sufficient. If you're going to do single gene testing serially, every time you do anything, any one of those things is to be reasonable and necessary. If you're doing a panel, the panel itself has to be reasonable and necessary. Consider the panel as a service, just like a single gene test is a service. Now, that idea I just mentioned about if one thing in that panel is not reasonable and necessary, the whole panel is not reasonable and necessary. We do not think that way anymore. So, for example, with NGS particularly, the cost of adding one more gene to an NGS panel is vanishingly small with every additional gene. So the idea that you could non-cover a panel because there's one thing on that panel that's not reasonable and necessary doesn't make much sense anymore. Not just from a cost perspective, but the reality is that our role at CMS or for CMS is to pay for services that are reasonable and necessary. It's not to not pay for services that are not reasonable and necessary. And while those two concepts might seem the same, they're really not. If 9 genes on that panel are reasonable and necessary and one is not, we'll pay for the service because the service is reasonable and necessary. I hope that addresses the question.
Okay.
I'll address another question I see here for PGX testing, since that's a hot topic. Do you need to show CV and CU for the panel for each gene in the panel? I think that basically I've addressed that, provided that the panel has all the required necessary relevant genes or alleles really, then anything you add on top of that, we don't care. But we're not going to pay you more for stuff that's not reasonable and necessary. We're going to pay you for the stuff that is reasonable and necessary. Okay. There are other questions on pharmacogenomics. I can't get into the details of what's in the final policy because I can't, until you guys see the final policy, I can't really comment on what exactly is in there. All right, here's an NCD question. Would the new NCD language allow for the same test to be covered on the grounds of suspicion of a new mutation on the same gene having appeared? The typical example VGR. Okay, that was actually my example. The answer is yes, it would allow for that. Can you comment on the new proposed LCD for liquid biopsies for transplantation? I cannot comment because that policy is currently in the comment period. I urge you, if you have comments on that policy, to please submit them to your MAC. It'll eventually come back to us, and we'll look at them. It appears that your slide states that LCDs can be more restrictive than NCDs, but LCDs cannot be more restrictive than NCDs. Okay, so LCDs cannot supersede an NCD. That's clear. But there are sometimes NCDs that allow MAC discretion over other components of a related service, in which case it can be more restrictive. So let's, for example, talk about NCD 90.2. It states that if you have an FDA-approved test that fits the criteria of NCD 90.2, then you're nationally covered. If you have a lab-developed test that fits under the same criteria for coverage, for example, that the patient has that meets the definition of advanced cancer and wants additional therapy and has not been tested with the same test, then MACs have discretion to cover. And how MACs have discretion to cover lab-developed tests is not defined in the NCD. So it can be more restrictive than what the NCD says because it doesn't actually supersede the language of the NCD. Okay. Is avoidance of treatment, not prescribing antibiotics, an intervention? I think so, but many discussions have not recognized this aspect. I would say that I don't know if it's an intervention. I don't know if that's the right term, but it certainly is a decision-making step. And if the question really centers around whether there would be clinical utility in not prescribing an antibiotic, I think that the answer could be yes. It depends, right? If giving that antibiotic has a definitive negative consequence or potential for negative consequence for that patient, then absolutely yes. If it's a societal question, whether driving antibiotic resistance in the general population, then the answer would be no, because it's not specific to the patient. It's not discussing a malformed body member, basically saying, how does this relate to this specific patient? Medicare in general is defined and specific to the Medicare beneficiary themselves and not their communities.
How much time do you have, Gabe? Maybe just for a couple more questions?
Sure. Yeah, I guess we were over. I wasn't paying attention. I have a few more minutes as long as people want me to ask a few more questions. There's another comment on clinical utility. Does not always change patient management. For example, sometimes a test is necessary to see if a drug treatment is working. You're right that the test does not have to change patient management. It has to inform the physician and have the potential to change patient management. If it doesn't have the potential to change patient management, it does not have clinical utility. Okay, can you comment or clarify the comment that generally molecular testing is not covered unless there is a policy that defines coverage? Is that in writing somewhere? It is in writing, and that's the MCL policy. It's the molecular diagnostic MDT policy. Sorry, molecular diagnostic testing policy, which is the first MolDX policy that basically identifies the process for coverage for molecular diagnostic testing, identifying the fact that a lot of these issues that I raised from a understanding of what's reasonable and necessary perspective can't really be done without a technical assessment. And also that language is also being written into all future policies as well, or at least our coverage articles as well. What are the criterion in terms of publications to show clinical validity and utility to show favorable outcomes for patient treatment management? So this is a good question. This is the kind of thing we discuss when people come in for the meetings, the face-to-face meetings. So there are no rigid criteria. This is where we employ our professional expertise and judgment. So for example, we could make the rule that you must have 5 publicly reviewed or peer-reviewed papers all in Nature, right? That would be a very high bar that would not be fair to anybody. We could say that it's 10 papers total. But the reality is some papers are great papers and some papers are terrible. Sometimes you've got all the right controls in place, and even a single paper can really be very convincing provided that it's done properly. So there are no established criteria. You must be able to be convincing with your data is the bottom line. We do request that the data be, or we do demand that the data be peer reviewed, because you could tell us anything. Now, you need to demonstrate that, again, in a peer-reviewed journal to make sure that other people also agree with your findings. Okay, any other questions that I didn't hit on that people want me to hit on?
I think you've brought up a lot of great points, and there's a lot of room for more discussion. I think we're just running out of time. I'm just looking. So I think we really are just running out of time, unfortunately, and maybe at a future date, we'll be able to revisit this and get into more depth. Gabe, you've been very generous with your time today, and we thank you very much. We strive to bring value to this industry with our leadership series, and we'd like the audience's feedback regarding this session and suggestions for future topics. So we'll be sending a brief survey and would appreciate your input. This series has been sponsored by myself and Executive BioSearch, leading search firm specializing in molecular diagnostic and life science tools domain. We recruit leaders at many levels for startups to well-established companies. So if we can be a resource for you, please contact us. That's our commercial. Thank you very much for your time, and we really look forward to your participation in our next session. Gabe, thank you very much for spending the time with us.
Thank you, Matt. Thanks for inviting me, and hope everyone's doing well at home.
We do too. Everybody stay safe and healthy, and appreciate it. Take care.